Good morning, everybody. Good afternoon. I am Louise Merrigan, and I work with Betsy Boyd Flynn at the OAFP. And today we are very happy to have some of our friends from ORPRN who will be discussing social determinants of health and accountable health communities in Oregon. First, we will start with Bruce Goldberg. Bruce is the ORPRN Senior Advisor. And prior to joining ORPRN in 2015, Bruce served 2 Oregon governors as the director of the Oregon Office for Health Policy and Research and the director of the Oregon Department of Human Services. He was the founding director of the Oregon Health Authority, and he's also been a practicing clinician, a county health officer, a medical director for a managed care organization, as well as a teacher. And that's it. Now, Anne is also from ORPRN. She's the Associate ORPRN Director for Healthcare Initiatives. And Anne has worked in healthcare research and administration at OHSU for over 17 years. And in addition to her roles as Associate ORPRN Director of Healthcare Initiatives, she is the Project Director for the Accountable Health Communities Project. This project has been working to implement social determinants screening and navigation for Medicaid and Medicare members in Oregon counties, in 9 Oregon counties. Anne also serves as principal investigator for several projects focusing on improving health and healthcare for Oregon's Medicaid populations. And finally, we have Zoe Rothberg. Zoe joined ORPRN in 2020, this year, after interning with the SHARP, which is Sharing History Through Active Reminiscence and Photo Imagery study at OHSU, and with Oregon State Rep Karen Power. She earned a Bachelor's of Arts in Sociology and Anthropology from Lewis and Clark College. So welcome, everyone. And with that, I think we will start our webinar. I'm turning it over to the 3 of you.
Fantastic. Glad to be here. I'm Bruce Goldberg. I'm going to kick things off. I'm actually just the opening act for the real part of this, which is Anne and Zoe, who are going to share with you some, I just think, really important and profound information about social need in Oregon that we've been researching. But before that, I wanted to just sort of introduce things by talking about the context of this work and really the context that we've been doing nationally. And Anne, if you could just go to the 3rd slide. And, I think this goes without saying, we know that healthcare costs are growing faster than other economic indicators. And, the issue there is that healthcare then steals money from education and other needed social services. And you'll see what the need is in a moment. That our healthcare system continues to unfortunately have varied and very inconsistent outcomes, and that we don't get the quality that we would like. We know every day we're reminded, particularly during COVID, of the widespread health disparities and the failure of our healthcare system and of our nation to equitably address healthcare and some tragic health disparities. And you'll see that in the data that we present around social need, which is, I think, a real contributor to that, and we can discuss that. And then I think lastly is this growing evidence of the importance of social services, investments in social need, care coordination, and primary care as the ways to really improve our health. The next slide, Anne. This slide shouldn't be unfamiliar to anybody here in Oregon. Actually, the next one. Yeah, there we go. This is a lot of what we've based our health reforms on here in Oregon, that when you look at what contributes to our health, it's more about where we live and poverty and education and what we eat and drink, and only about 10% of it is medical care. And so if we're going to get healthy, it's how do we address these other factors? Next slide. You know, we also are reminded every day that we spend more than any other nation in healthcare. This is some work done by Liz Bradley at Yale. And, you know, she showed that, you know, what we all know, that we spend a lot more than just about every developed nation, not just about. We spend more than every developed nation, in some cases twice as much. You know, but the issue is, and it's the next slide, you know, we talk about the fact that we spend a lot of money on healthcare, but we don't get the outcomes we need. And Liz's hypothesis is that the issue is that it's not the money we're spending on healthcare, it's that we're spending so little on social and human services. And this is the ratio of social service to healthcare spending. And you can see the little American flag there, way out on the right. You know, the issue is we spend the most on healthcare, but when you look at the ratio of healthcare versus social spending, we spend very little. So if we're going to work our way out of this, most of these other countries get the better outcomes they get, not just about healthcare spend, but about social and human services spend. Next slide. You know, and there's a real opportunity cost in that. And I think that's what we all forget, is that if we prevent one emergency department visit that we don't need, that can actually translate into 1 month's rent for somebody. That 2 avoidable hospitalizations or a year of childcare. You know, 20 MRIs that maybe shouldn't have happened is a social worker. 60 echocardiograms is a public school teacher for a year. I mean, we can go on and on and on with these things, but I think the issue is the more we can become more efficient in our healthcare system, we can actually help transfer the dollars into investments in human services. So last couple of points, if we go to the next slide. You know, I think we're learning that social investments can help. We certainly are learning the effects of social need on healthcare. People with social needs get fewer preventive services. They use more emergency room visits. They have increased chronic healthcare conditions, higher readmission rates, poorer health outcomes. So the issue is, how do we address the social need to bring some of those down? If we go to the next slide, there's some actually great examples coming in from around the country about the fact that if you do invest in social issues, you do improve health. These are just some examples around housing and health, but they show that, you know, housing improvements for people with lung disease improved asthma scores and reduced healthcare costs. When housing was provided for low-income elders with care coordination, they had reduced emergency department visits and unplanned hospitalizations, and they ended up in nursing homes less. That when there was housing for chronically ill, homeless, and those with severe substance abuse, that they saw a real decrease in healthcare spending. And likewise, supported housing reduced overall healthcare costs and lower emergency department visits. We have a great example here in Portland, Bud Clark Commons, and a great evaluation done by the folks at CORE that showed that those individuals who live in Bud Clark Commons with housing and wraparound services have seen dramatic decreases in their Medicaid expenditures. Last slide, and then I'm going to turn it over to Anne and Zoe. You know, we have a lot to learn. We don't know what social factors have the greatest impacts on health. We know social factors do, but which one should we address first? Who can benefit the most from intervening? What are the best ways to determine need? Who should pay for these? I mean, there are many, many, many questions, but I think as you'll see in a moment from the work we've been doing that this is a huge problem in our community, I think bigger than many people even understand. And that if we're going to work our way out of this problem, we're going to change the way we approach things to address these social factors. So with that, I'm going to turn it over to Anne and Zoe. We're going to talk to you about the screening we've been doing, and most importantly, about the results we've seen after having screened over about 12,000 people here in this state. So Anne, all yours.
Thanks, Bruce. So I'm just gonna, for those of you who aren't aware of what the project entails, I'm gonna just go through some of the basics. So the Accountable Health Community Study is funded by CMS, and really the way that we designed it and our approach to the work was to make it as much as possible a service to patients and a resource for clinicians. And so the project involves screening patients to understand their social needs. And these are Medicaid and Medicare beneficiaries. And we look at their housing, food, utilities, transportation, and safety needs. And when someone does have a need, they're provided information about available social services, hours, location, prerequisites, what type of paperwork they need to fill out, that sort of thing. And then for patients who are considered high risk, and for this model, that means they've been in the emergency department 2 or more times in the prior year, they get offered help from a patient navigator to access services. And those folks are generally nurse case managers and community health workers and others who are trusted. For the most part, it's trusted staff from the local clinic or agency. And then for many of the sites, the needs that the patient expresses are documented in the medical record for provider use and care planning. As Bruce said, we're in many counties at this point. There are 9 CCOs that are involved in the project. We've had more than 50 clinical sites that have participated, and we'll talk about the change since COVID in a minute. And then this state and also local agencies have been quite involved in this project, trying to understand what works. So the screening tool itself, we do have a structured process and a screening tool that we use. It was developed by CMS and tested, and it is standard across all sites. It takes about 5 to 10 minutes to administer the tool. We're finding that the conversations with patients when we talk to them are much longer in some cases, but the tool itself is relatively short, can be used in a waiting room while someone's waiting for a visit. We have it in multiple languages and have many materials in English and Spanish. And so lots of details about that. If anyone's interested, you can reach out to us after. And it can be accessed online and used on a desktop, a phone, a tablet, or a lot of clinics are using good old paper. This is just a picture of one of the community resource summaries. We pull the data from 211 info, and then we prioritize it in a way that an algorithm that we came up with at the beginning of the project to try to get the most relevant resources near the front of the list for the patient. So the navigation process for those deemed high risk, as I said, the navigators are often the trusted employees from the patient's clinic. In some cases, the navigators are 211 info workers who are really knowledgeable about how to access resources and in some cases able to fill out state paperwork with someone online. So they work on a care plan, documenting past efforts, barriers, and goals to work on specific needs. They help with referrals, sometimes connecting with agencies, setting up transportation or translation services or whatever is needed. And then they do follow-up for up to a year, depending on the situation and the desires of the patient. And they document what happened. And so we have a fairly rich data set for this smaller, this is about 8% of the population that's screened end up in this cohort. And we document what happened in terms of whether they were able to access social services or not. So with the advent of COVID-19, there have been a lot of changes. And in particular, a lot of clinics have found that their volume has reduced to the point where they don't have the staff on hand to do this type of activity. There have been worries about infection control with passing out things like paper or tablets, et cetera. So there was a pretty big pause over the course of the spring in screening. That has started to pick up again at this point. So you'll see if you look at the graph, prior to COVID-19, 98% of the screenings happening for this project were done by the clinics themselves, clinic staff. And with the advent of COVID-19, we have expanded the study staff considerably. We hired 27 people. And so we're doing phone and text screening, and 211 is doing more navigation at this point. And so we've watched that ratio continue to shift where clinics are coming back online. There's even more screening happening locally. And so overall, we're all together doing more screening now. So we're screening about 700 people a week, and then doing all of the follow-up that we described. So our findings to date, and as we're going, if you have questions, you want to just chat in to the chat, feel free to do that because we can then make sure we get to address them, or we can also hold them to the end. So our findings to date, so as Bruce said, as of the end of August, which is the last time we refreshed all of these numbers, we were at about 12,000 screens. We're probably at about maybe, I don't know, 14,000 at this point. And of those, and these are Medicaid and Medicare beneficiaries, 43% overall have had a social need. And that has been about 23% of the Medicare patients and 52% of the Medicaid patients. And again, they've had at least one of those 5 needs: housing, food, utilities, transportation, and safety. The needs of the population screened thus far, food and housing have been the dominant needs throughout the study, with Medicaid patients reporting food needs, 38% of Medicaid patients and 27% disclosing housing needs. And then for Medicare, food and housing have been 13% overall. And then you can see transportation, utilities, and safety are lower reported needs. And then the percent of unmet social need by region, we looked at, we kind of divide this project into regions. So the Portland metro area, 58% of Medicaid patients and 32% of Medicare are reporting unmet social needs in the Portland metro area. In Yamhill, it's 47% and 22%. And then you can see Central Oregon and Southern Oregon are somewhat similar. All right, so I am going to turn it over to Zoe, who's going to talk about what we've seen in terms of social need since COVID-19.
Hi, my name is Zoe. I'm a research assistant with our team, and I do a lot of outreach calls myself, as well as lead a team of some of our new staff that we hired to help with outreach calls. And from my perspective, just doing the calls, I'm talking to a lot of patients who are just experiencing a lot of uncertainty. And even if they are not responding and saying that they're having social needs, they're talking about just the lack of stability and the constant wondering of what's next. And in addition to helping connect these patients with resources at 211 Info, we are also able to help connect them with primary care physicians, specialty doctors, and mail order pharmacies if they're interested in those resources as well. Next slide, Anne. So just to start with a comment from one of our providers at a screening site, they said, "I told my team just today that we are restarting screenings next week. I think it is so important, especially given how many people are really at risk right now. People are definitely struggling. My Hispanic patients are truly in the worst straits. They are at risk of losing housing. They are relying on the free school meals to feed their children. They are trying to help children with school from home, and they do not speak English, and most have no education at all. And as one would suspect, they are having health consequences." So this provider is highlighting the impacts COVID is having on already vulnerable populations, and we will see these impacts also reflected in some of the data in the next slides. So just a quick overview. Prior to COVID-19, which we are marking the start of COVID-19 as March 23rd, which is when Governor Kate Brown announced the stay-at-home order. So prior to March 23rd, 48% of our Medicaid respondents had a social need, and after the beginning of COVID, that number went up to 70% of Medicaid respondents having a social need. And in terms of Medicare respondents prior to COVID, 22% had a social need, and that number increased to 44% after the start of COVID, both of which are huge increases. So in this chart, we're looking at the needs that we screened for and the increase in needs since the beginning of COVID. So we screened for food, housing, transportation, utility, and safety needs. And as you can see, food and housing are the highest needs, and both have had the most significant increases since the beginning of COVID. Prior to COVID, 27% of those that we screened had a food need, and that number increased all the way up to 48% after the beginning of COVID. And again, prior to COVID, 20% of those we screened had a housing need, and that number increased to 39% after COVID. I also want to highlight the safety need. While that increase was not as significant, it is a noteworthy need because it's an important resource. At the beginning of COVID, there was a lot of conversations about the potential increase in domestic violence with more people staying at home, and this increase could be a reflection of some of those speculations. We also believe that our safety needs may be underreported for reasons such as that we're calling patients, they might not be comfortable disclosing information over the phone, or they might not be comfortable disclosing information to people they don't necessarily know at all. We also have safety protocols for each of our outreach teams where we can do warm handoffs to crisis lines. We can connect patients to social workers at their medical home. We can refer them to certain providers. And sometimes the patients just want to stay on the line with us to talk and clear their heads and reduce social isolation in a sense. So this slide, we are looking at the statewide food needs before and after COVID. We have asked 2 food questions. We asked patients how often in the last 12 months they were worried about running out of food, and if in the last 12 months they ever did run out of food. So prior to COVID, 24% of those we screened were worried about running out of food. And after COVID, that number went up to 49% of those who we screened worried about running out of food. And in terms of those who did run out of food, 22% prior to COVID responded that yes, they did at some stage in the last 12 months run out of food. And after COVID, 44% of those we spoke with said that at some stage in the last 12 months, they ran out of food. And just anecdotally, as I'm doing the screenings, I see patients who are responding yes to the question where we ask if they do run out of food. They're also responding yes to the question that they're worried about running out of food. So these worries are not without cause. This slide is showing the increase in housing needs after the start of COVID. So prior to COVID, of those we talked to, 6% those we talked to were worried about losing housing. And after COVID, that number went up to 18% of people who we spoke to worried about losing housing. And then prior to COVID, 3% of those who we spoke with had no steady housing, and that number has increased to 10% after COVID. The next couple slides depict some of the racial and ethnic disparities we're seeing. Next slide. This first slide is the unmet needs in the Latinx population prior to COVID and after COVID. And again, after COVID, we said as March 23rd, with the stay-at-home order. So again, we're seeing in this population, food and housing are the most significant needs. And after COVID, both of those have had the most significant increases in needs among the population we spoke with. Next slide. This slide is the unmet needs in non-Latinx populations. I just want to highlight that this sample size is much larger than the Latinx population we were able to connect with. But again, we're seeing similar trends with food and housing being already the most significant needs. And then after the start of COVID, these needs being the most significant increase. Again, I want to highlight the safety need here. And in this final slide, we're looking at the unmet needs by race. Prior to COVID, all non-white races, except for Asian, already had a much higher percentage of needs than those who identified as white. And after COVID, all races had a higher increase of needs, especially those who identified as non-white.
Thanks, Zoe. So just talking about closing gaps in services. So one of the things that we're responsible to do for this project is work on partnering with community agencies and statewide agencies to try to use our data to identify gaps in available services and figure out how we might help to address them. And so, of course, as you saw in the data, food has been the most, has been the predominant need that's been shared with us. And so we've been working with the Oregon Food Bank to identify gaps and work with communities on closing them in food distribution. So we've held what we're calling food summits in Yamhill County, Jackson County, and Josephine counties so far. We have one coming up in Central Oregon. And really, we have had some really good successes with these in terms of getting the healthcare and community agency staff together, sharing data and identifying what each sector has seen as challenges. And so these are some examples of some of the outcomes of these summits. We've had a couple of hospitals that have recognizing the gap in food availability and also challenges with transportation for patients have decided that they need to add a food distribution location within their facility. And so they've done that in collaboration with the Oregon Food Bank and the local food banks. There's been work towards a medically tailored meals program that is for Medicaid patients that's connected with available food from the local food banks. There's been work to increase transportation options to help patients obtain food from the food banks. One of the gaps that we heard in one region was there was no bus stop at the food bank. And so a lot of Medicaid patients were unable to get to the food bank to get food. And then there were even small gaps that we heard, such as if there aren't bags available for people to take food home from the food bank or from the local distribution locations, like the ones in the clinics or the hospitals, that they won't take very much food, even though they need it. So little things like that can be major obstacles for patients who need food. And finally, we've heard that in one of our food summits that patients were feeling like the food bank staff maybe weren't as trauma informed as the community health workers at the clinics. And so it was decided by all involved that the staff from the clinic would come and provide training to food bank volunteers and staff, but it's mostly the volunteers that just, you know, benefited from some training in trauma-informed care. So lessons learned, there's significant burdens in screening for social needs on clinics. It's just another responsibility for busy clinicians and staff. It adds time to an already very short visit, and it's challenging to get a screening tool administered prior to the provider visit. And really, I think there's some consensus that having that information available during the provider visit is really a gold standard. Social needs screening and all of the activities that happen to help patients with their social needs, it's a very fast-moving landscape. There are a lot of requests of clinics from various entities to use different tools, different approaches to report data. And there are a lot of groups that are trying to figure this out on their own. And it's a very challenging field right now. And clearly there aren't enough resources either within clinic or community resources available to meet the needs. And in Oregon, food has been a somewhat easier area for us to work in that there are, the Oregon Food Bank has enough fresh produce and foodstuffs to meet the need. The challenges with food are really around distribution, refrigeration, transportation, things like that, but there's enough food. Housing is a whole different story. There's, in most communities, not enough housing for low-income people, Medicaid members and seniors. And so addressing housing needs is really, really challenging. And then the social service sector is already quite overloaded and resource strapped, as Bruce expressed, and asking them to track data, return information, which actually is part of the study we have not been doing. We've put the burden on the healthcare sector to, and which is getting paid to do this, which is collecting that information. As CMS is not permitting any of the grant dollars to go to the social service sector. However, it's very challenging for the social service sector to handle one last request, and particularly something like a study. Some other learnings, a lot of what we've learned has been around workflows. I think I already expressed that there's just not enough time. We've done a lot of observation of clinics and different clinic models, and certainly there's been so much process engineering in clinic visits that there's just no waste in the system. There's no time to say, okay, here's the ideal moment to talk with someone about their needs. It really requires patient report. And then how do you get that information from, before a clinic visit and get it in front of a provider in a way that's consumable and usable in care planning? We have learned that patients are willing to take social needs surveys in clinic. They're also willing to talk on the phone, but while most patients will agree to take the survey in the clinic, we're finding maybe 50–60% of people are willing to talk about it on the phone with a stranger. But the ones that are willing are really positive about the outreach, and especially now. And we like to tell our team that we're working on, we're at least solving some social isolation needs right now, even if we're not fulfilling all social needs. So we have implemented texting, and texting absolutely works in terms of reducing the burden of follow-up calling and that sort of thing, patients do respond. It's somewhere around as high as 20% is what we're finding, depending on the population of the clinic. And some patients, that's their preferred method of communication. So we are using texting in some settings as the first outreach to the patient, and then follow-up calling if they don't respond to text. Another finding is with the advent of more telemedicine since COVID-19 started, patients or clinics have tried to incorporate our process into telemedicine. And it's a very difficult thing to do that with a study because we have a pretty robust consent form and requirements from the IRB to accomplish it in a certain way. And so clinics that did try to come online with their telemedicine visits found it difficult to do this. That said, I think there's definitely space to study whether a shorter, maybe 2-question screen that isn't part of a study without a consent might be something that could be done within telemedicine easily. We're not sure, but it's something worth studying. And then finally, the screening process on the phone, it can take about 30 minutes. Patients are really interested in talking to our team, telling them what's going on. As Zoe said, we're covering COVID-19 discussions, like do you have access to medication? Do you need help with mail order pharmacy? Identifying other barriers, like people who are not, haven't been into primary care in a long time, or need help with getting DME and other things. So, and then there's the social isolation is huge, particularly we're talking to a lot of people who have been in the emergency department recently, or even in the last year, and people who are not particularly mobile. And it's definitely, I think, a bit of a lifeline to have the group call them and one of our staff and ask how things are going. So it's certainly not a small undertaking to do this. Another finding has been, as Zoe showed, huge disparities by race and ethnicity. And sensitive questions can be really difficult for staff and patients. I think the interpersonal violence questions have definitely been, difficult to navigate, and our teams had to be very well trained to help patients, not to act as their provider, but to get them to the right place, whether it be the domestic violence hotline or the suicide hotline, getting their social workers from their clinics involved and that sort of thing. But it's certainly particularly those questions have been complex. And then it's important to point out, while a lot of the screening tools available right now for social needs screening have been studied, they've often been studied in small populations, not particularly diverse populations. And so I think it's hard to say that a screening tool is evidence-based. The Accountable Health Communities tool was studied. There was a fair amount of research that went into it, but we're still finding there's some populations for which it's not ideal. One of the things we hear a lot in our work is the desire for a coordinated and statewide approach to this work. And I think that goes along with this is a fast-moving landscape comment from earlier, that, we're certainly, there's so much of this going on and it's being done differently. And, how do you share information across health and social service agencies if we have real different type of data being collected and different ways of recording this information, et cetera. And I think just finally, you know, we're finding from the data on navigation that many of the needs are being addressed. We have a huge pick list that people can, that the navigators select from when they're closing out a navigation. And it looks at things like services not being available in the community, or the patient not being qualified for the service, services not being culturally acceptable, things like that. So we've developed it with some of our CCO partners, and it's about 20 options. And really mostly what we're seeing is that the needs are being addressed from the patient and navigator point of view at the end of the service. That doesn't mean that they don't just pop up again, you know, next week if someone loses their housing or loses their job or what have you. But at the close of the navigation, many of the needs are being recorded as addressed. So we're going to pause here. We have a number of, I'm going to turn it back over to Bruce to answer some questions. We have a number of questions in the chat. So Bruce, I'm going to read. Do you want me to read them?
I think people can read them.
Okay, we'll let you just go for it.
Let me address, there have been a couple of questions. Jim raised a number of important issues about how attitudes of individuals versus about how helpful local agencies were in addressing their needs, some issues around housing density, undocumented individuals, and addressing systemic racism. And I think these are all extremely important issues. Unfortunately, they're not issues that our study is addressing. You know, this was, I don't think we gave as much background. You know, we're one of 20 sites around the country doing this work. And it is, there's a clear sort of study design by CMS in terms of the population to screen. We're screening only Medicare and Medicaid recipients. We're not screening anyone else, so we don't have any information on them. And, as I think you've seen, the ability just to collect this information has been, taxing for clinics and for others. And so the ability to collect additional information, while we think is incredibly important, and some really great issues have been raised, they're certainly not things that we've been able to address in this study. Having said that, this is the first and what we think is the only systematic screening that's gone on in Oregon about social need. And we have always hoped that this would generate and be a platform for community activism and for organizing locally around these issues. And indeed, we've started to see some of that with the food summits that Anne has mentioned and some other activities. I think, unfortunately, some of that has been short-circuited a bit by COVID, but hopefully we'll pick up after that. It was also a great question by Nancy Elder about, are we collecting any qualitative information from the phone calls? And, again, unfortunately, no. When we began this study, we weren't doing phone calls. Most of the information, most of the screening was being generated by clinics and others. I think it's a hugely important question. And in fact, interestingly enough, there is a PhD student who is looking at doing her thesis around attitudes of individuals who are being screened. And, I think we know very, very little about the attitudes and some of the qualitative info from individuals who are being screened, are at risk, and how they're dealing with these. So hopefully, like most things, we will, this work will help, we hope generate some additional work, but our ability to do some of this has unfortunately been limited. And, Louise had a question in there about any advice we'd want to share with family physicians to help provide their patients with the needed services. So I would say a couple things. And then I look to Anne for some additional comments on this and the other questions. First and foremost, I think what this study shows family docs is the incredible amount of need out there. And that there, I think, has been oftentimes a reluctance to screen because of a fear that we couldn't help meet some of those needs. So, my advice is, one, I think this shows the incredible importance of screening. And I would say, in terms of helping provide patients with needed services, I think what we've demonstrated is that, there are a number of local resources. And the issue is not for practices to provide people needed services. Medical offices aren't housing agencies, nor are they food banks. But what they can do is help provide people information about resources in their community. And we've put together resource directories, but it's been really interesting as we've worked with a number of practices and in a number of locations. They've already developed their own resources. They know where people in the community can do some of that, can get some of their needs met. And, that's been really helpful. So, I don't know, Anne, what other thoughts do you have?
Yeah, I mean, I thought you stated it all of this very clearly, Bruce. Some of the things that we are working on understanding is the clinic side of the effort. So there's not really a piece of the study that looks at provider or clinic comfort level with this work, how they feel about the best workflows and that sort of thing. And we have a paper that we're working on and some qualitative work in that area. And then, as Bruce said, we're also looking at how patients feel about the navigation portion of the project. That one of our PhD candidate students, who I thought was on this line, but I don't see her, is working on. So I think there's just a lot of open questions and not enough research and published papers on this work. And it's been a tremendous opportunity to be able to do what we've done so far and partner with so many clinics.
Could I make a comment? I know that in speaking with our family physicians in Wallowa County does not have a public health department. And so one of the clinics there has been taking over a lot of the public health needs of the community. And one of the things that some of the clinicians have said there is that when they ask their patients about what their needs are, the first time, the second time, they're not really open to expressing that they have a significant need. But sometimes the third time that they ask, the patient will open up and let them know that yes, they have a need for housing, they have a need for food, they have a need for medication, And because the clinic has, it's Winding Waters Clinic, because the clinic has taken over some of that public health responsibility, they find that they're able to place people in hotels and help people grocery shop and pick up medications and different things like that because they're working together because they are the public health. So I'm wondering if there are in communities where public health and primary care could, you know, essentially work together. You know, that's just a thought.
Yeah, I think that's certainly one important thing that can happen. I think the bigger issue is that this is ultimately a public policy issue. And, I don't think we can look to primary care practices to address what are large systemic public policy issues around food insecurity, hunger, racism, and housing and transportation. Certainly, we all play a role. Our hope in this study was twofold. One was to start to screen individuals and connect them to services, and we've been able to do that. And the other has been this larger systemic assessment of being able to actually document the extreme needs in communities to be able to move a public policy dialogue towards addressing some of this. It's been one thing for communities to say we have a housing problem. It's been another thing when these communities have come together and said, we know of 1,000 people in our community who have indicated that they have, housing insecurity, or 3,000 families that are food insecure. It's been, a pretty powerful tool. So I think there's not one answer to all this, and certainly, partnerships between primary care and public health are really important.
Yeah, and I'll add to that, as our relationships between clinics, partnerships between clinics and coordinated care organizations, which also have the ability to support health-related resources to help patients with urgent needs.
Great. Any other questions?
I'd just like to mention, if you would be willing to share those resources with us, then we can share those with our members. The community resources, that would be great. We probably have some of them already, but just to have those to share would be terrific. And the other thing I want to mention is please make sure that you fill out the survey, which we have provided in the chat. Because that's the only way that we'll know that you've attended, and then we'll get your certificate of attendance out to you, because this webinar is eligible for 1 hour of prescribed credit.
Great.
And if there are no more questions, I would really like to thank the three of you for being here today and for doing this very important work. We have recorded this webinar, and it will be available for others and for people who would like to watch it again. It's really informative, and thank you.
It's been our pleasure. Thanks, everybody.